This morning. I hope everybody approves and likes it. My name is, where am I get my clicker going here? My name is Anderson Rice. I'm with Kaiser Permanente. I work in the addiction medicine department. So I'm a supervisor there. I supervise a team of 7 full-time clinicians, outpatient services, and we work alongside a medical team who does outpatient detox and handles other issues. Just yesterday, a giant FU emanated down the hallway as a patient stormed out. Can anybody relate to that? Has anybody ever had that happen? No, never. How's the temperature in here? Right? Most of you have hair. I don't, and believe me, this will show you the temperature quicker than you can imagine. So you just shake it off a little bit. We need a little calisthenics going here. Okay, so I'm going to talk about, I'm the behavioral health guy, as I've already said. So I'm going to be talking about trauma, pain. You know, what we've heard so far is around pain and all the interesting medical data. You're going to get a lot more of that. Of course, if we're talking about pain, we need to talk about PTSD, okay? I'm thinking about that picture of the shark, right? So, we treat the injuries, and then imagine that. There may be some trauma as a result of that within the nervous system. So I'm going to talk about a specific somatic modality that will perhaps give you more information about an approach we would take to work with PTSD. First I want to say thanks to the organizers again and to the other presenters. I know I've learned a lot by doing these and working with this group, and I think that I appreciate the spirit of this, which is getting different disciplines together, and hopefully that's the experience that you can have today, okay? So let's just jump right in. And I'll warn you, this is about 10 pounds of rocks in a 5-pound bag, so we'll see how we do here. I left my phone timing-wise down there if someone wants to cue me if I start to go over. So most of us have, we've heard the term PTSD, right? And we could grab the DSM, which is the Diagnostic and Statistical Manual for Mental Health. That's how we would arrive at a diagnosis of PTSD. But I think it's helpful to look at the description of trauma through some different lenses, okay? So a lot of my work is informed by a guy named Peter Levine. Anybody heard of Peter Levine, Somatic Experiencing? Well, let me ask this. How many behavioral health care providers are in the room today? Okay, wow, that's a pretty strong showing. So let's just dive into this. Peter would say trauma happens when the organism is strained beyond its adaptational capacity to regulate states of arousal, okay? And I'm going to talk more about this adaptational capacity. Humans possess regulatory mechanisms virtually identical to those in animals. These systems are often overridden by net cortical inhibition, right, the rational mind. This restraint leads to the formation of a constellation of symptoms including pain, patterns of bracing and collapse, cognitive dysfunction, anxiety, and a sense of intrusion. Okay, so we've got these natural systems and rhythms in place that help us deal with stressors and traumatic events as we experience them. And then this speaks to when things get out of balance or dysregulated. Another description, Bessel van der Kolk, traumatized people chronically feel unsafe inside their bodies. The past is alive in the form of gnawing interior discomfort. Excuse me. Okay. Their bodies are constantly bombarded by visceral warning signs, and in an attempt to control these processes, they often become expert at ignoring their gut feelings and in numbing awareness of what is played out inside. They learn to hide from themselves. So what I like about this quote is that it speaks to this sort of internal dissonance that's happening for people who have trauma. So when Thomas put the picture of the basketball player up and I looked around the room, what do you think I saw? A lot of wincing, and except for some of you hardcore medical providers who, have seen things I never have, but it can be troubling. So imagine if you're actually the person who's lying there on that court with your bone hanging out of your leg, and then let's amplify that by, Thomas touched on this, everybody freaking out, right? You're not even feeling pain, and then your brain's going, oh my God, something's really wrong. I was feeling like, I don't know, some pain, and now everybody is in crisis. So what starts to happen is that can create dysregulation, and that can create a compartmentalization as well. And so you've probably heard of the term dissociation, right? So that's this compartmentalization of when certain areas of the brain are overly firing, right? Others are going offline, okay? And this is just, a nice picture of a very thoughtful Tim Robbins. Bad luck, I guess. It floats around. It's got to land on somebody. It was my turn, that's all. I was in the path of the tornado. I just didn't expect the storm would last as long as it has. You know what movie that's from? Quiz? Yeah, it's a classic, right? It's wonderful. So some other ways of seeing trauma, I think these are fascinating. This is a photographer, Claire Felici, who assembled these triptychs of the Netherlands Marine Corps soldiers before, during, and after deployment, okay, in active combat. She then arranged the portraits into these triptychs. So if we look at the picture on the left compared to the right and then the transformation, if you may notice some subtle cues that they're different, but if you really take a second to study it, things to look for: an aliveness in the eyes, almost like the skin is more supple and it could be more expressive on the left, sort of a nice natural range of affect. So if you were riding the Max and someone walked up to you to engage in conversation, would you rather be the person on the left or the person on the right? You don't have to answer that. It's okay. So let's go to the next one. Here's this left picture of a nice sort of wry smile on a young man. Eyes are full of life, and as we move through the transformation, I mean, look at the difference in those eyes. Suspicious, maybe paranoid, fearful, right? Again, through the mouth, there's almost a frozen quality happening there. Number 3, what I think is interesting about this photograph is how it's almost like the physiology around the eyes has changed. There's a narrowing, and it's almost more stone-like. And so this is trauma, right? And so as I move forward and I'm talking about a somatic approach to trauma, the idea is that, you could try to tell this person, hey, snap out of it. Just think your way out of it. But the systems that are out of regulation to create this sort of transformation in somebody, we're talking about the whole mind and body. We're talking about the whole nervous system, okay? Okay. So what does a healthy nervous system look like? Observables. I bet a lot of people in this room have many of these qualities, right? A person will be relaxed and at ease. The body and its senses will be relaxed yet alert. They're present through all layers of the self, right? Physical, emotional, psychological, spiritual. Physiology is appropriately responsive to a variety of circumstances. My head is cold, right? That's appropriate. Responses are fluid and resilient. They're available for connection. They're emotionally stable. There's an experience of having choices and options. There's a freedom in that perception, and there's a capacity for healthy relationships. Okay? Does that sound like your life? Maybe a little bit. Some of you, yeah, or maybe your colleagues, or whatever the case may be. Maybe not all of your colleagues. I don't know. So let's talk more about Peter Levine's work, if we're talking about the whole mind and body. So what happens when we're faced with a traumatic event? This massive energy is mobilized as part of the survival system. Okay, so fastball is flying at your head, okay, and how does your body react? Hopefully it moves, right? Okay? So all of a sudden, without you having to think about it, everything mobilizes, and you move probably faster. I don't know, for me, faster than I've moved in years, if that was happening to me. So what happens, what in his studies and looking into other people's studies, was that animals spontaneously discharge this energy. So we have this massive energy mobilization, and then animals just sort of, think about the possum, right? Everybody has seen those BBC footage of the possum. What do? They play dead, right? So what happens when the possum gets up? It kind of gets up and sort of shakes itself off and goes about its business and goes on being a possum, right? We don't necessarily do that. If we're in a freeze state where we're completely shut down, we don't necessarily bounce back as quickly. So that became a real pursuit of Peter's. Prey animals are rarely traumatized. So what happens, and again, this is where it's, we could spend days talking about this approach. It really requires it. But somatic work facilitates the completion of self-protective motor responses. So I'll say more about that. It really is about, there's a strong mindfulness component to this. There's a strong component of getting people into their bodies and beginning to experience sensations that they are avoiding, okay? That's an important piece. Now, this idea of self-protective motor responses, I've worked with patients where I start to see movement come through the body in ways where the movement was not completed. So let's say someone's in a head-on car collision. What are our bodies probably going to want to do? Put our hands up, right? Does that make sense? Whoa, this thing is coming at me. I've worked with people who didn't have that opportunity, and what's interesting is they will start to report that this self-protective motor response wants to come through. Okay, if you were filming this, it might look a little woo-woo, but I can assure you that there's an organic quality to the body wanting to complete these cycles. Okay, this is tapped into a very ancient survival system. So a somatic approach is not driven by content or retelling of the story, and it's also very slow and supported. Okay, what do I mean by that? Most therapists who are doing trauma work have people just sit down and, all right, tell me the story from beginning to end, and we're going to do that over and over and over again. Okay, now that works for some people, but I've worked with a lot of patients who say, all I do is get re-traumatized when that happens. Okay, it's like you're making me stare at that basketball player picture who happens to be me, and then give you the nuanced data over and over and over again. And working in addictions, I've had so many people tell me that they really wanted to go get loaded after their therapy appointments. Big surprise, right? That was awful. Therapy sucks. I want to get drunk, right? This is how it can play out. So the idea, and this is really where the field is growing, okay? And again, I'm not saying this is exposure therapy if you're having someone tell the story over and over again. It does work for some people, but we need to have other modalities, and that awareness is increasing greatly. So let's take a look at the way, Levine's work and Stephen Porges and the polyvagal theory. There's a ton written about this, but there's some basic breakdowns of the way the nervous system is compartmentalized and the way the different systems fire together. So we've heard of fight and flight, right? That's like household term at this point. That's part of that sympathetic nervous system. Okay, we know what that is. And then we have freeze, which is part of the parasympathetic nervous system. That's the emergency shutdown switch. Like this is the big master switch in the basement, right? I'm not fighting my way out of this. I can't run away from this. Boom, I'm just going completely still, right? And people who have had long extended periods of freeze responses, like in inescapable, situations where they weren't able to escape from, held hostage, things of that nature, you're going to see a lot more freeze coming through in the work. But this fourth place is the social engagement system. This is part of the parasympathetic nervous system. So that is our relationship with people and our ability to be online and get support from others. So what's the first thing you're probably going to do if you fall overboard from the cruise ship? I don't know, from the sailboat. What do you? Help, right? Somebody help me, right? And then what do we promote in our patients? Asking for help. You're going to quit smoking. Let everybody know. That's all about social engagement and support, okay? Because really, physically, we're kind of wimps, right? From an evolutionary perspective. A little spider can send us into fits, okay? But we've got these brains, and we've figured out other ways of staying alive. But we also have community, and we have each other. We are pack animals, right? So this is a very important piece. Now let's look at the healthy nervous system on a nice graphic here. So there's a nice organic flow that we experience in our lives, again, with this sort of healthy nervous system. I'll give you an example. You have a tense interaction with somebody, or you wake up and see the news this morning. We won't go there, right? And voices are raised. You're going to have a sympathetic activation. Okay, your heart rate may go up. You may start to experience anger, some sweatiness in the palms. You decide to take a break from the conversation and go for a walk and clear your head. This starts to tap into the parasympathetic nervous system. Okay, and we really kind of move through the days like this. Okay, and sort of this nice organic flow to the system. Okay, so self-care comes into play. Vacations come into play, right? All of these things that we enjoy. Now let's take a look at what happens when a traumatic event comes in, right? So the traumatic event occurs. The traumatic stress is not discharged, so somewhere the system gets stuck, right? And then this is a key term, dysregulated begins to happen. So this nice flow is now this event comes in, and people's nervous systems can really start to look like this, okay? That looks a little more chaotic and stressful, doesn't it? Now, many of our patients are presenting like this, okay? Things are really whacked out. But sometimes the perception is this is a characterological issue, right? This person's just a jerk. Well, they may be acting like a jerk, but there may be a very real reason that they're unable to regulate how they're presenting. And then you factor in addiction, and that makes things even more complex. If they're stuck on, you're going to see a lot of anxiety, panic, hyperactivity, exaggerated startle response, inability to relax. I'm working with a patient right now, like she cannot turn off her startle response. She can't have anybody behind her. Going out in public is hell for her, okay? And she knows it. She doesn't want to feel this way. So we're working a lot on trying to get this switch to turn off. Stuck on off is we're looking at depression, flat affect, lethargy, deadness, exhaustion. And as medical providers, there may be other syndromes to be on the lookout for where a trauma could be a layer to it, low blood pressure, poor digestion, things of that nature. It's pretty interesting, isn't it? I love this graphic. It's a great one. This is just a breakdown of that list. I made it bigger. I already went through a lot of this. You see pain is on here, chronic pain, etc. So coming back to this, because I want to say more about social engagement as part of the parasympathetic system. Has anyone seen? You probably can't see it. Has anyone seen this cartoon? It's a Far Side cartoon. What we say to dogs: "Okay, Ginger, I've had it. You stay out of the garbage. Understand, Ginger? Stay out of the garbage, or else." And then what Ginger hears is blah 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 Ginger. Blah, 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 Ginger, blah, 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 Ginger, right? I love that. And, of course, you have to speak to what cats hear. Fluffy, they hear nothing, right? The ultimate in aloof is the kitty cat. And I love his characters. Miss Gary Larson, boy. So let's talk about that, though, because, let me speak to this. When someone is in high sympathetic arousal, and their social engagement system is not online, guess what? When you're talking to them, it's more like this. Blah, 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 meds. Blah, 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 boom. Blah, 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 blah. And if someone's really activated in that way, when I've had people go into like anxiety or panic when they're in session with me, they're not really hearing my voice, right? So I'll start to cue them and try to ground them. And one of the ways I check in with them is, can you hear me? Can you reflect back what you're hearing? Okay. I mean, I try to avoid that, but it does happen. So that's something to keep in mind. So what's going on there? Well, we want to try to create conditions to get this ventral vagal system online, right? It's part of this whole vagus nerve system because, again, it down-regulates the sympathetic system, okay? Calming. Often this is the first attempt to create safety. This is unique to mammals. So in my world, there's a common fact about what's the most important thing for people's success in therapy. Anybody want to shout out what that is? The relationship, right? Exactly. Not them doing our will, right? But the relationship. That's the juice, right? And so good clinicians start there. Start forming a relationship, having an engagement, getting to know people, creating safety, creating conditions, as opposed to what's the problem? What brings you in here today? How do we fix it? Boom, 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 boom. Let's go. Let's slow it down a little bit, okay? How does this impact how we interact with our patients? I know some of us have serious time constraints. Maybe you got 20 minutes or 15 minutes, but that interaction is worth looking at. How do we start our sessions? How do we start our appointments, right? What's the content of our patient discussion? Some patients are going to come in, they just want, I call it red versus blue. Red is just everything that's wrong, and it's like a run-on sentence. Anybody have patients like this? Mm-hmm. Yeah, of course, right? And then, and you can see them elevating, right? So maybe we can try to shape the content and get into resourcing and that relationship. What's the tone of voice? What's our tone of voice? What's our body language? Are we sort of like, oh man, or can we sort of lean in and be open, right? How do we roll with their resistance? So in motivational interviewing, I'm sure most of us have probably heard of this. It's like, how do we respond to this baseball flying at us, right? Do we get out of the way, or do we try to hit back, right? Not literally hit. Come on. Bear work with me. What are their interests? How much do we know about our patients? I can tell you when one of my patients is coming in and I can tell they're really activated, where do we start? Oh, have you been riding your bike? Have you been jogging? How's that going? When was the last time you did something fun, right? When was the last time in the last week you felt like yourself or most like yourself? And that you can see the entire system start to relax. Oh, yeah, I went for this run yesterday. I did 9 miles. It was incredible. Or we went for a hike at the beach. This is not just like chit-chat. I used to think this was chit-chat as a therapist. I was always going to the red, addictions and intensity. And now what would maybe look like just sort of chit-chat is resourcing. Okay, I'm very intentional about it. And that's important. That's important. You will see people relax. Try it. It's pretty interesting. And then how are the surroundings of where we're doing our work, right? Is it, how's the temperature, right? Are there sharp objects left out? I don't know. Where's the door? Where's the chair? Where are they sitting? Some of my patients are really specific about where they want me to sit and where they want to sit, okay? Because if you've got trauma, you're going to walk in this room, depending on the trauma, and you're going to immediately know where all the exit signs are, right? Where can I get away? Right? Okay, so some other ways, this is just some ideas, what was going on in your life when the pain started, for chronic pain. Now be careful, because you may get a very long answer. So I think this is important, but, right, there's ways of getting it back on track. And many patients report that they don't even feel like their MD believes them. My doc doesn't believe me, right? So I'm just going to touch on this real quick. Some common symptoms that traumatic response coupled with physical injury that you may see. Again, this could imply that there's some unresolved nervous system trauma going on. Is recovery may be slow. Scars may appear that they've not healed properly. General amnesia about what happened. Fragmented reports of the experience. If there's chronic pain from a car wreck, these are things to be aware of. Unrealistic fears associated with the experience. General malaise. They're often ill. There's chronic inflammation. Hypochondriasis, right? It may not always be trauma, but it's worth checking out, okay? Some syndromes that could be tied to sympathetic and parasympathetic mediated dynamics, migraines, fibromyalgia, autoimmune disorders, pain syndromes, IBS, chronic fatigue. Again, if this is going on, it might be worth some other discussions. So let's talk about some other approaches to trauma treatment. How am I doing on time? Can I check in? Oh, wow, okay. We'll be doing a very long meditation in a moment. No, I'm just kidding. So another Gary Larson gem here. Exposure therapy, which is rooted in behaviorism. I'm already laughing. Behaviorism, gradual exposure to stimulus in order to minimize fear. Now, Professor Gallagher clearly didn't get the memo on gradual, right? So his controversial technique of simultaneously confronting the fear of heights, snakes, and the dark. For those of you who can't see, there's multiple snakes crawling on this poor man, and the door's locked. It's not necessarily dark, but you get the idea. he's so great because I love how the professor is just, no expression. It's very interesting. Imaginal exposure therapy, and I should say this looks more like fear of driving over bridges, right? Start by getting in the car, you approach the bridge, you're with somebody, you're practicing your coping skills, and you go back to where you started, and then eventually you get to the point where you're actually driving over the bridge. There's a lot of value in that, but it has to be facilitated very carefully. Okay. Imaginal exposure therapy, as I mentioned, is telling the story, telling the story, telling the story, telling the story. Let's look at some others. EMDR, people have probably heard of EMDR. I'm not going to get into the specifics. You can read more about it. Eye movement, desensitization, and reprocessing. It has to do with the different hemispheres of the brain and a light system that triggers that, and then a way of associating with a therapist, and then a way of interpreting what comes out of that. Of course, Thomas mentioned cognitive behavioral therapy, probably one of the most well-known approaches to treatment. So with a trauma focus, it's recognizing negative thought patterns and beliefs in order to change the behavior. You start here, and then it moves forward into the actions, okay, negative thinking patterns, and it's tried and true, right? CBT. Dialectical behavioral therapy, have people heard of DBT, the mighty DBT, originally developed by Marsha Linehan for very acute, what is called borderline or high suicidality, very chaotic, disorganized folks, and it's really expanded. These are skills and techniques that can be applied to various populations. They're rooted in mindfulness, among other things, and behavior change. What's interesting about DBT is this idea of embracing these seemingly opposite ideas of acceptance and change with skills that are taught to modify behavior, feelings, thoughts, and beliefs. So that's the dialectic. So DBT really embraces this idea of paradox, paradoxical ideas, and that both exist, okay? Because, many times patients can get into this either-or thinking, or, I can get into either-or thinking, and it really asks us to hold all the different things that are going on. There's 4 main branches of the DBT tree there. There's distress tolerance, right? Handling distress. Emotional regulation. So if you go think about that graphic that I presented, emotional regulation, right? Mindfulness, okay? And then there's interpersonal effectiveness, which is teaching people how to be more successful in relationships and communicate. What does that remind you of, right? Getting the ventral vagal system online. So this can be a really nice add-on to trauma work, okay? Here's a sort of the most famous, I think, graphic that comes out of DBT. It embraces this tension of opposites. So you've got this rational mind, right? Then you've got this emotional mind, and the idea is that we want to work with people to help hold both, and that creates what is the wise mind. This also gets into, I use the term loosely, a spiritual question that arises for a lot of patients, clients. What is my wise mind? And I think a lot of people find an avenue into a deeper belief system that may be there for them, right? So acceptance and change, pleasure and pain, emotions and thoughts. A good example of this is I can receive negative feedback as a valued employee, right? That's holding the dialectic, as opposed to I receive this feedback and, oh my God, they hate me, okay? Does that make sense? Thomas also had a brief Star Trek character. You everybody see that? So I've used that for this as well, where rational mind is, come on, Spock, thank you. Emotional mind, there's some debate about this, but who's the emotional mind? Maybe Kirk. I'd say McCoy, right? McCoy's very histrionic, right? Or Scotty, maybe. And then we have I always think of Kirk maybe as being the wise mind. I don't know. Like Kirk can be very measured and strategic, or very romantic, I guess. Kirk can also be first interracial kiss on TV. Everybody know? Yeah, Uhura and Captain Kirk. You didn't know that, or maybe you did. I think that's a wonderful factoid. So I can receive negative feedback as a valued employee. So what is that wise mind? How do we bring these parts together? So other therapeutic modalities, if you saw, I don't know, if you were here last time, this is a new content that I was happy to include per request, which is talking more about mindfulness and how, and Thomas touched on some of this also. And what about pain? What about depression? What about anxiety? All of these things that can come out of pain issues or trauma issues. So 2 modalities I'm going to touch on. There's mindfulness-based stress reduction, and there's acceptance and commitment therapy. John Kabat-Zinn, MBSR, and then ACT comes out of the work of Stephen Hayes. And that's a great, the McCracken study that Thomas talked about. You can, if you Google ACT chronic pain, it's like in the first couple hits, and it's a really great article. I would recommend that. Let's move forward. So let's define mindfulness versus mindlessness, okay? Mindfulness means paying attention in a particular way, on purpose, in the present moment, without judgment. Isn't that nice? I think that's nice. Isn't that easy? Piece of cake, right? So paying attention in a particular way means having intentionality about it, right? What are we doing? On purpose, again, more intentionality. Trying to stay in the present moment without judgment. And in all the groups I've done, it's, everybody agrees, we just have this here and now moment, but we're our heads, right? We're planners, we ruminate about the past, we have memories. So there's a lot of work that can happen there. And then whatever is arising in the mind, not having judgment about it, that's easy, right? I'm joking. It's not easy. It can be very challenging. MBSR was founded in 1979 by John Kabat-Zinn to work with pain patients, okay? So he'd had his own experience with meditation out of Eastern philosophies. But he's very clear that, I wrote MBRP, that's relapse prevention, that MBSR is a secular form of mindfulness, okay? It's research-based now. There's a lot of data around it. But in 79, he began accepting referrals from docs at the UMass Medical School for pain patients. And he had a little room in the basement, is my understanding, and he just began to work MBSR with folks, okay? Now, why was he doing this? The idea around this was that he was trying to change the perception and the relationship to pain for folks, okay? I'll say more about that. First, let's introduce ACT, acceptance and commitment therapy, also has a strong mindfulness component. And then Stephen Hayes' work has focused a lot on relational frame theory. So I'll give you an example. But it's around this idea, and again, Thomas mentioned this, is trying to get rid of your pain only amplifies it, okay? So the brain and the way it connects, when we're trying not to think of something, it actually gets louder. So, pink elephants. What do you think of? Or pink elephants, right? Okay, now don't think about pink elephants. Okay. I think you should stop thinking about pink elephants. No, really, don't think about pink elephants. So don't do it. No pink elephants. What happens? Of course, by putting our attention to something we're trying not to think about, we are thinking about it. Okay? It's just the way it works. So that's an example of the amplification around that. So what's important about that? Okay? I don't want to feel this. I don't want to feel this. I don't want to feel this. I don't want to have a panic attack. I don't want to have a panic attack. Oh, shit. I think I'm going to have a panic attack. Excuse my language. Hope no one has a panic attack. Distinguish pain from suffering is another part of this. Okay, so this idea that I can be with it. I can develop a different relationship with it. I can experience pain. That McCracken study touches on that. Okay? And it's the struggle with pain that causes the suffering. Okay? And I've been in long meditation periods where I thought the pain was so bad in my knee that I was going to run screaming out of the room. And what was interesting is I had experiences where if I just sat and looked at the pain, next thing I knew, 15 minutes later, like the pain was gone. Maybe because I was numb. I don't know. But the pain did change. My relationship with the pain changed. It was very interesting. And then ACT takes in this idea of commitment and values. And that is this piece around, are you living the life that you want to live? So not only can I acknowledge that the pain is there, but can I take steps to move into my life despite the pain, right? And that was that second item of that McCracken basis. So all this is explored with folks. So mindfulness says there's a development of the observer self that just watches change, right? Building psychological flexibility in the context of the patient's values, okay? So the values could be the container in ACT. Learn to notice thoughts rather than acting on them, okay? Anybody have that experience in traffic ever in Portland? You know, you have these thoughts and then you don't act on them, and then I sometimes see people who are acting on those thoughts. That's never a good sign, right? Everybody sort of slows down and tries to get out of the way of the road rage that can happen. Asking questions like, is this even true, right? For example, I can't do anything useful because of my pain. Like, it's over, right? The pain may still be there, but the patient's relationship to it can change. So that's ACT and MBSR. There's a ton written about it. I'd recommend it. Stephen's book is called Get Out of Your Mind and Into Your Life. I think it's a pretty cool title. So the other piece around this as providers is pointing you towards some resources if you're trying to find ways to refer people. Psychology today, if you need a therapist and you're not part of an organization that has a behavioral health department that you can just refer to, as a wonderful way of searching and finding folks with specific areas of focus. TraumaHealing.org is a link to a somatic experiencing site. You can find a local, they're called SE therapists, most of whom are licensed also. EMDRIA.org, EMDR resource, and then findcbt.org. This is in the slide deck that went out also. Just some specific books around these emerging somatic approaches to trauma if you're interested. In An Unspoken Voice, How the Body Releases Trauma and Restores Goodness is Levine's work. The Body Keeps the Score is a very popular Bessel van der Kolk book, Mind and the Body and the Healing of Trauma, and The Body Bears the Burden, Trauma, Dissociation, and Disease. And then John Kabat-Zinn is, I think, one of his most well-known books. It's called Full Catastrophe Living. Right, I'm seeing a head nod back there. This, how do we live with the catastrophe, right? How do we move forward? And that ends my portion. Thank you very much. Mm-hmm.